Assalamu alaikum, good afternoon everybody. This is a quick review of management of cervical dysplasia. Just to refresh our mind about the cervical dysplasia, as we said before, it's not a diagnosis of pap smears as cytology. However, it's a diagnosis confirmed by having colposcopic assessment and colposcopic biopsies, and then you have CIN, so you can determine which degree of dysplasia you have, and then you diagnose and manage the patient accordingly. Remember, histopathology is the diagnosis. You have CIN 1 or 2 or 3 or carcinoma in situ. In general, once you do the biopsy, you can tell your patient is cervical dysplasia as CIN 1 or 2 or 3. Remember, CIN 3 now is merged with carcinoma in situ. Roughly, it's the same diagnosis. There is no invasion, so there is no cancer. Always remember, management, if you're gonna follow, I'm talking about the ideal management. I'm not talking about what's going on sometimes in the private or other hospitals. The ideal management, if you have a patient with CIN1, is doing nothing, meaning you don't need to do any intervention, you don't need to do any excisional procedures for the patient. You need just to follow the patient every 6 months, because there is a very high likelihood, almost 70%, the patient will clear the viral infection and will clear the cervical dysplasia. So there is no indication to intervene unless the patient insisted to do a procedure as excisional procedure, but you have to tell the patient this is not the standard of care. However, CIN 2 and 3, this is where you need to treat the patient, because we know that the likelihood of progression to carcinoma is higher and the likelihood of regression to normal is very low, and that's why you need to offer the patient any method for treatment of the dysplasia. Remember, by the end of the day, all the methods, whatever you use, will give the patient almost 90% cure rate. You have to tell the patient very clearly that there is 90%, meaning you cannot guarantee by doing the excisional procedure, surgical or non-surgical, that the patient will be cured 100%. Always remember the number, 90% applicable to any excisional procedure. The available methods could be cryotherapy, which is very easy and simple. You can do it in the clinic. Could be CO2 laser, and again you can do CO2 laser as evaporation, or you can do it as conization. You can do the LEAP, which is loop electrosurgical excisional procedure, as a cone, or you can do a cold knife cone biopsy. If you want to do any ablative procedure, you have to make sure that it is satisfactory colposcopy, meaning you did sample the ectocervix and the endocervix is fine or clear. And if you can review what is the meaning or definition of satisfactory colposcopy in the previous lecture. The biopsies, to confirm that there is a CIN 2 or 3, and you have to have a negative endocervical cortage. As we said before, you can do ablative procedure like cryo, or you can do another ablative procedure like CO2 laser ablation. Both are acceptable, but the only downside that there is no tissue diagnosis to confirm the diagnosis by the end of the procedure. So cryosurgery, this is mostly, as I said, used. It could be done by any obstetrician and gynecologist. Very safe, non-expensive, and again, the local destruction usually, because of the freezing, will causes necrosis of the dysplastic cells, and that will cause the cure. You can use what you call it, the copper and the silver cryoprobe tip. It's between 19 to 25. It depends upon the cervix and it depends upon the area. Usually you can you can use different gases. You can use carbon dioxide, you can use nitrous oxide, or you can use the freon gas. Each one has its own temperature. By the end of the day, the cure rate will be the same. There is no preference. It depends upon the center wherever you are working. Regarding the cryosurgery, it's painless procedure. As I said before, it's easy. You don't need a special training for that. You attach the probe for 3 minutes at least, and then you can have the ice ball. You try to have it like around zero 0.5 or 5 millimeters margin. The efficacy is quoted to be 90%. There is always 20% risk of having watery discharge. You can tell the patient. Very rare, causing complications like stenosis or dystocia, which is around 1 to 3%. Photo laser, this is one of the best methods we can use, which is not very aggressive. However, you need a special training and you have to improve your safety margin in the usage about the personnel. Make sure the setup is okay. You can do it as an office procedure, or you can do it in the main OR. You can do it with cervical block or paracervical block. It's CO2 laser, as I said before. It causes evaporation. You can use ultra pulse mode, which is 35 watt. Depth usually 5 to 8 millimeters, but it depends. If you want to go to the vagina usually it's superficial, so you go around 3 millimeters. It causes evaporation. If you're gonna do cervical evaporation, you can do cutting, but honestly, cutting needs a very special training, and I've never seen anybody doing cutting anymore. But again, it's a it's a center dependent. But always remember, you need to do an ECC prior to evaporation, because this is mandatory to make sure that the endocervix is how the cervix looks like after the CO2 laser evaporation. And the instructions for the technique itself, as we said before, you have a special training, and everybody should wear the protective eye, what do you call it, wear, and also at the same time, you may use the non-reflective speculum, and all the tools should be non-reflective. You need to drape the patient. Always you have to familiarize yourself with the what do you call it, the laser machine, CO2 laser or any type of laser. But this is the intensity where you need to go between 600 to 1200 watt per centimeter square. Spot size, the smaller the spot, the more the stronger. The wider the spot, it will be more of hemostatic action. And this is how it looks like, the speculum, which is non-reflective. Conization, this is what we call it, a cone biopsy. Cone biopsy could be a cold knife biopsy. People sometimes they think cone biopsy is always cold knife. It is not. You can do it by laser cone, as I said before. You can do it by leap cone, and you can do it by cold knife cone. I always advise to do an ECC, which is endocervical cortage, after the procedure. And as we can see here, the cone is around 2 by 2 centimeters, the usual. But usually you try to be more gentle on younger patients who wants to preserve their fertility. You have to be more aggressive in a patient who's perimenopausal or postmenopausal who did complete their family. Procedure for cold knife conization, as you know that you can do it again under IV sedation with paracervical block, but you have to make sure that the patient is very comfy, because a simple jerky movement may cause a lots of complications, may cause perforation of the cervix or extension to the uterines. But in general, you have to make sure that she's very well sedated. As we said, it's around 2 by 2 centimeters, and that will cover the ectocervix and the endocervix. This is how it looks from outside. So it will cover the ectocervix and endocervix, and the area or the idea of doing the ECC is to cover the area in the apex of the cone and the remaining endocervical canal, to make sure it's clear and not affected by dysplasia or cancer. The hemostatic suture, which I do, and I think this is the best, honestly, it's called stem derf sutures. Very effective method of using zero vicryl as a hemostatic sutures. Inshallah, we'll provide a video if we do a cone biopsy, a supplementary video, and this is how it looks like. So it's outside, inside, inside, outside, upper part, and then outside, inside, inside, outside, lower part, and then you tie it all together. And most of the time it helps. You can do any type of sutures, whatever you're comfy with, but always remember, because you're injecting local as xylocaine with epinephrine, it gives you an impression of hemostasis, but after 2 hours it will resolve. And you always advise the patient not to have intercourse for 2 weeks, as well as nothing but per vagina for 2 weeks. No agents, no anything, no tampon, nothing for 6 weeks also. As we said before, you can use vasopressin or epinephrine. For hemostasis, you can do packing if needed. Sometimes we use Monsell solution, or cautery will be fine. That will help to decrease the preoperative blood loss, as well as decreases the menstrual period. But in general, you can tell the patient that she may have more cramps during the first few cycles after the cone biopsy, which is called loop electrosurgical excision procedure. And this is different loops for different sizes, but in general, as we said, it's another type of cone. They call it leap cone. So again, the leap, you can do it as an office procedure. You can do it with IV sedation, cervical block, or paracervical block, or regional or general. You can do it any way you like. Usually, the cervix is infiltrated, and then you can use the generator 30 to 40 watts. But remember, we use blended. So the more you use coagulation, the less it will be cutting, and vice versa. But usually we try to use the blended because it's a mixture, so it will give you good cutting along with good hemostasis or coagulation. The CO2 laser cone, as I said, it needs a skillful operator. Honestly, I don't do it and I've never seen it, but we used to do CO2 laser evaporation. And again, it should be in the OR. You can do it under GA or regional, but in general, you have to do it colposcopic guided. And the margins, usually you can mark it with dots before you start. And usually the power use 1000 to 1500 watt per centimeter square. Of the conization is very like low or unlikely to happen, but in general you might have interoperative bleeding, uterine perforation with some major complications. As I said before, jerky movement of the patient is the most common risk factor. You may have post-op bleeding, especially what you call it early, like within 48 hours, but sometimes we instruct the patient it may happen after 2 weeks. This is where the scar falls down, which is 5 to 15%. Infection, late complications, cervical insufficiency, or cervical stenosis, which is quoted to be 1 to 3%, but it depends upon which procedure. So this is the likelihood of cervical stenosis or cervical insufficiency. And as I said, the more the younger the patient, you have to be more gentle and try to avoid cold knife conization. Typical question, which is the best method to use? There is nothing like the best or what is the best for this patient. It depends. You have to individualize your management according to the patient, or you tailor it according to the patient. But again, in general, if you have or if you don't need a tissue diagnosis, you can go for ablative. The availability, experience of the operator, the cost and convenience of the patient, and future reproductive plan. This is very important. But in general, if procedures, however, I recommend doing the other procedures, a procedure where you can have a tissue diagnosis to confirm the diagnosis. And again, it depends upon the, remember, whatever you use, it will give you 90% cure rate. Remember, you tell the patient 90% cure rate, you tell the patient she will need a pap smear in a regular basis, lifelong, in an annual basis, because she had a history of dysplasia. Remember, you have to have at least 3 negative colposcopic assessment with biopsies if needed, with pap smear as per routine. You need to do it every 6 months. So repeat the pap smear with colposcopic assessment after the procedure every 6 months time 3. If all the biopsies and all the colposcopies were negative, you can discharge the patient for a follow-up as an annual checkups, and that will be the cure, inshallah.